ready to roll yet.
Let me double check. Okay, good afternoon, everyone. Here we go again. My second pleasure today is to introduce our second keynote speaker, Dan Kotecki. Dan is currently the Assistant Vice President for Operational Excellence at the Cancer Treatment Centers of America. CTCA is a national provider of cancer care with a network of 5 regional medical centers that are committed to providing patient-centered care to cancer patients and their caregivers. In his role, he is responsible for ensuring the effective execution of strategic enterprise-wide programs and initiatives, as well as deploying the CTCA Operational Excellence System. It's my great pleasure to welcome Dan Kotecki.
Thank you. All right. Thanks, Randall, and thank you. You're incredibly kind, and thanks to all of you for allowing me the opportunity today to share a little bit about Cancer Treatment Centers of America and how we're working to translate our strategic plan into efficient execution every day. I must note today is a pretty special day for me. It is my wife's birthday, so I'm really looking forward to enjoying some time with her after today, this session today. And I also realized as I was getting up here that I must have drawn the short straw a bit. I got the slot right after lunch. So the only one worse than that is the one right before we're ready to depart. So I will do my absolute best to keep this group energized and get you guys off to another great breakout session this afternoon. Let's see here. For my talk today, I wanted to spend a little bit of time sharing a little bit about who CTCA is. Then give you a sense of the dynamic and rapidly changing market that CTCA is competing in today. And after that, I'd like to talk a little bit then about how CTCA has aligned its organization to operate effectively in that environment and some of the results we're seeing to date. And finally, it wouldn't be a good story without talking a bit about lessons learned along the way, and I want to share those with you as well. So let's start with the overview of who CTCA is. Randall gave a bit of a background, and as you mentioned, CTCA is a national healthcare system made up of 5 comprehensive cancer care centers and now 3 outpatient care centers as well. We treat over 15,000 patients annually from all 50 states. And in fact, patients travel an average of 350 miles to receive care at one of our centers. We have 800 plus physicians and clinicians who are treating over 125 different cancers. And each year we receive 30 million visitors to our website seeking care or answers to questions about their care. So we have a pretty big platform. And we do this all while maintaining a patient satisfaction level of much higher than 90%. And we do this by attempting to eliminate the major challenges associated with cancer care today. To illustrate this, I wanted to share a little bit of a story and walk through a typical cancer patient's experience. In fact, it's not unlike one that was experienced by my father here recently. And I wanted to contrast that a bit with CTCA's approach to care. So imagine you're a 55-year-old male patient going to see your primary care physician for your annual prostate cancer screening. And your primary care physician orders the necessary blood work, does the digital exam, and notices that the prostate's a little enlarged and mentions that to you and says, you know what, go home, we're gonna get the results of the blood test. And so patient is at home waiting for a couple days till the blood tests come back. When the results come back, lo and behold, the PSA count level is higher than expected, and it's causing the primary care physician to then go ahead and refer you to a urologist to go get that checked out and get a biopsy to see what we're dealing with. So, problem is, the urologist isn't available for about a week, so the waiting game starts to begin. But ultimately, you get in and you see the urologist and the biopsy is conducted. Unfortunately, it's going to be another week before you hear back what the results of that biopsy are. When the patient finally gets back in the room with the urologist and the biopsy results come back, in fact, the diagnosis is revealed, in fact, you do have cancer. But we're not exactly sure how far it's progressed, so that urologist then is going to order some tests, probably some scans to go see how far that disease has progressed, and may even refer you to an oncologist at that point. Again, you're going to have to travel somewhere to another office, get on a waiting list to go see that physician, as well as the imaging center where your CAT scan or your MRI might be conducted. So again, another week or two of waiting while you're trying to juggle work and everything else in between. Finally, the scans, you get in, scans come back, and the results are passed to the medical oncologist, and now you find out that, in fact, the cancer is not just in the prostate, but is it spread to some other organs as well. So the oncologist starts to share the various treatment options that might be available to you, which could include some combination of chemotherapy, radiation therapy, potentially some surgical procedures as well. But he wants to send you to a radiation oncologist as well as a surgical oncologist to go talk to those physicians as well. Again, it might be another week before you can get into those providers to understand what you may be dealing with or what options are available to you in their domain. So in total, at this point, by the time you actually see the radiation oncologist and the surgical oncologist and the medical oncologist and get all the facts you need to make a good decision about what's the next step in your care, maybe 4 to 6 weeks have passed, anxiety-filled weeks, as you're trying to understand, what you're wrestling with, and this big word of cancer. What does that mean for me? So once treatment begins, there is a strong likelihood that there's going to be side effects of some kind related to the treatment that you're going to undergo. For example, malnutrition may set in as a result of loss of appetite for chemotherapy, and then now there's a whole host of other complementary services that you may need or support services like nutrition therapy, naturopathic therapy, etc. So another set of appointments and providers to manage. CTCA has attempted to eliminate much of that by putting the patient at the center of all that we do. And we do that by putting all of these services under one roof as best as we can, which allows us to deliver answers quickly to patients and provide services conveniently all in one place. So you don't have to travel all over to different providers across your town or county or state. With that said, I wanted to transition a bit into kind of the strategic environment in which CTCA is currently operating in. And healthcare as a marketplace is pretty complicated, probably not unlike the marketplaces you all work in as well. You have, of course, the providers. You have the patients. You also have the payers who are essentially paying the bills for services received by patients. You have, and by the way, you have the government involved as well, as they're one of the largest payers for healthcare in the nation. And then you also have regulators involved. So if we take and kind of peel back the different dimensions there, what I point out is that we know that cancer incidence globally is growing. In fact, it's growing by about 2.5% each and every year, and that nearly 1 in every 2 males will receive a cancer diagnosis at some point in their life, and 1 out of every 3 females will. And as a result of this, the drug market is essentially booming, and in fact, the revenues are expected to reach about $150 billion annually by 2020. The great news is that over time, survival rates of cancer patients have increased steadily, aided largely by drug advancements, new surgical techniques, and innovative radiation therapies. So you can see here that over time, for nearly all cancer types, survival rates have increased. From a competitive perspective, the top quality national cancer care was essentially relatively sparse. If we went back all the way to 1967, which is like ancient times from my point of view, there were probably about 7. Sorry. There are probably about 7 to 8 significant national players in cancer care. Fast forward to today, and you can see that picture is rapidly changing. In fact, when you consider not just those national cancer centers, but start to consider their affiliates, satellite clinics, et cetera, the competition is even more stark. On a payer side, there are also a number of recent shifts in the healthcare marketplace, a lot of them associated with the Affordable Care Act. In fact, payers are required to spend 80% of the premium dollars they collect on medical claims or care improvement activities, which is a good thing. They can no longer deny coverage due to pre-existing conditions. They are prohibited from placing annual lifetime dollar limits on a number of benefits. And in fact, children can remain on their parents' policies till the age of 26. All of these changes have created a really big challenge for the payers to manage their risk pools and hindering their ability to manage their losses. So the counterpoint to that is that payers are putting pressure on providers and patients to control costs. For example, payer networks are becoming much more narrow, often excluding specific specialists or specific institutions, limiting patient choice. Reimbursement rates for provided services are decreasing, and costs are being shifted to patients in the form of higher premiums, higher deductibles, and reduced coinsurance. Many of you probably are experiencing much of this as consumers of healthcare. So the strategic implications for Cancer Treatment Centers of America is that given the increased competition out there, we have to deliver on an incredibly compelling value proposition to encourage or incentivize, if you will, patients to travel 350 miles to come visit one of our centers. That's a pretty high bar. Decreasing reimbursement rates from payers require that we must deliver that value with much less than we have in the past. And given the rapid change in the healthcare market, the organization's strategy must be nimbly deployed in order to bridge the execution gap. So with the remainder of my time, I'd like to share a little bit of how we've aimed to do just that and what the impact of those efforts have been. So I want to spend a little bit of time talking about how we align the organization, because it's a big part of what we do. And I'm going to start with our vision and mission. It might seem cliche, but aligning an organization, it begins with an inspiring vision and mission. Ours are shown here, and I'd like to recite them for you. Our vision is to be recognized and trusted by people living with cancer as the premier center for healing and hope. And our mission is that Cancer Treatment Centers of America becomes the home of integrative and compassionate care. We never stop searching for and providing powerful and innovative therapies to heal the whole person, improve quality of life, and restore hope. This is what we rally our stakeholders around. And when I say stakeholders, it has a lot of implications, but to us, when I say stakeholders, I'm referring to our employees. And our vision and mission is actually anchored in CTCA's history. Cancer Treatment Centers of America was founded in 1988 by Richard J. Stevenson following the death of his mother, Mary Brown Stevenson, from cancer. After his mother was diagnosed from cancer, Richard and his family searched for the most advanced and effective treatments available. And they were disappointed to discover that the world-renowned cancer hospitals at the time were not focused on providing their mother with the comprehensive care and advanced treatment options she needed. Sadly, Mrs. Stevenson passed away before she could watch her grandchildren grow and mature. But to keep his mother's spirit alive, Richard vowed to change the face of cancer care. And he created a new model of care that changed the way oncologists, surgeons, and other clinical professionals treated patients with cancer. The whole-person cancer treatment approach, combined with a compassionate, nurturing environment, is now known as what we call the mother standard of care. And to put it simply, at CTCA, it is always and only about the patient. CTCA rallies its stakeholders around its vision, mission, and of course this mother standard by aligning our strategic objectives to a standardized operating framework. At a high level, our strategic objectives or strategic themes are pretty clear. We aim to improve the patient experience, provide innovative cancer therapies, extend services to more patients, support those patients across the care continuum, and provide care efficiently. And then we've mapped these strategic objectives, to a fixed operating framework comprised of 4 core pillars: committing to quality, grow, innovate, and engage. The pillars of our operating framework are defined by TrueNorth Metrics, and you're going to hear me talk a lot about TrueNorth Metrics in the next series of slides here. Those TrueNorth Metrics give meaning to these pillars and provide clarity to all levels of the organization on how we as an organization collectively measure success. For example, for commit to quality, success is measured by patient satisfaction and safety event communications. Growth success is defined by net revenue and new patient growth. Success in innovate is defined by operating margin and labor effectiveness. And for engage, success is shaped by the magnitude of stakeholder ideation and improvement implementation. These TrueNorth metrics are then integrated into just about everything we do, including enterprise and strategic initiatives that we deploy, departmental and functional KPIs, daily management and continuous improvement, our stakeholder incentive plan, and our performance management processes. Starting with the strategic and enterprise initiatives, they're all aligned to our operating framework and assessed against their ability to impact our TrueNorth metrics. If it isn't going to move the needle, it's probably not going to land on the project list. Additionally, these same TrueNorth metrics are incorporated into a closed-loop approach to operational excellence that links our stakeholder incentive plan performance to lean daily management, continuous improvement, and department-level key performance indicators. I'm going to talk a little bit about how that works. Our stakeholder incentive plan, which rewards all stakeholders in the organization for strong organizational performance, rests on CTCA's TrueNorth metrics, which are tied to quality, patient care, growth, productivity, and financial stewardship. Each month, stakeholders are updated on the performance of these metrics. These TrueNorth metrics are translated down to each and every department through CTCA's lean daily management approach, where each day, leaders of those departments are guiding their teams through a daily huddle where departmental performance is discussed and ideas for improvements are raised and ultimately implemented. These implemented improvements drive better performance in the departmental key performance indicators, which, you guessed it, are linked right to the organization's TrueNorth metrics, thereby creating a self-sustaining cycle to organizational improvement. If I dive down a little bit deeper into our daily management process, each day in each department, a huddle is held around a visual management board that you see here. The visual management board displays critical departmental news and information, the department's key performance indicators aligned to the pillars of the operating framework that we discussed. It also displays leading daily indicators that are translated down from those departmental KPIs. It also shows current improvement work underway in that department. During this huddle, important department and organizational news is shared. Yesterday's performance is reviewed and evaluated for improvement opportunities, and today's departmental readiness is assessed. Additionally, these huddles are rounded on regularly by executive leadership. These TrueNorth metrics are also embedded into our performance management process. In our approach, stakeholders are evaluated 50% against their contributions toward KPIs, and 50% against how well they've modeled CTCA's performance or behavioral standards. As mentioned earlier, all departmental KPIs are linked to CTCA's TrueNorth metrics, creating just one more reinforcing mechanism to ensure all employees across the organization are incentivized towards common goals. So, with all of this work to align the organization, and it is massive, so as I mentioned, we have 5 comprehensive care centers across the United States. Each of those hospitals has roughly between 40 and 50 departments that are doing this. So you can imagine that standing up 250 plus departments doing this process is a lot of work. So given the amount of attention that's been paid to this, one would ask, what are we seeing? What kind of results are we seeing? Is it worth it? And what I can say is that since the beginning of CTCA's journey, and I stress journey because it's not ended and we're still on it, towards operational excellence, enterprise impact has doubled each year from the initiatives developed and executed on by stakeholders, as well as those enterprise and strategic initiatives that members of my team are essentially performing a key role in driving. At a department level, some really interesting examples of the type of kind of breakthrough thinking we're seeing. For example, the scheduling team that manages all the patient scheduling, who's coming in, when are they coming in, redesigned their workflow to serve over 2,300 more patients each month with 5 less stakeholders. The pharmacy team improved their retail pharmacy experience by delivering patient prescriptions all throughout the hospital, which resulted in a reduced waiting time in the retail pharmacy area, increased medication compliance because we could ensure patients were going home with the medications that they needed, and it also led to an increase in revenue. Inpatient nursing has made remarkable gains on a number of clinical quality indicators like patient falls, infection rates, and pain management. And collectively, in this fiscal year alone, this is the metric I really think a lot about. It's core to what we're trying to drive from a cultural standpoint. Is we've had 2,500 improvement ideas generated by frontline stakeholders, and already 1,500 of them have been implemented this year. So really, really strong engagement at a frontline level. And in fact, it hasn't necessarily just resulted in internal improvements and internal impact. CTCA is recognized by leading healthcare organizations for a commitment to quality care, including organizations such as CMS, as well as Magnet and many, many others. So, along the way, a lot of lessons learned. I'd like to share a little bit of that with you. And while we've certainly achieved an incredible amount, we still have a long way to go in my mind as we aspire to kind of that perfect patient experience. With that in mind, I close with a few of those lessons now. From an organizational standpoint, it's critical that clear direction is expressed through your vision, mission, TrueNorth metrics to enable strategic alignment down to day-to-day operations. It's one thing to connect it to your strategic initiatives, but how do you engage the masses, the entire workforce, towards a common purpose, common goal? Because not everybody is going to be involved in every one of those strategic initiatives. Senior leadership has a really critical role here as well. They must help architect and drive the desired alignment. They must ensure that alignment is reinforced with other enabling mechanisms at our disposal. We walked through several of them today. And they need to be very clear about the expectations they set for performance and accountability. It's critical that middle management becomes experts in understanding and effectively communicating to their staff how their functions contribute to the overall success of the organization. And also very critical is that they empower their teams by serving as a coach. Said in a couple presentations today, and there was a lot of conversation about sometimes it feels like this is an initiative we're doing because my boss said we have to do it. It's missing the why behind what we're doing. And it's really, really critical that middle management becomes very, very strong in developing that the story behind the why. Why are we doing it? Why does it matter? How does it help the overall organization? And they must be able to track, trend, and monitor key performance indicators. And then I'd say the last one, on a frontline level, individual contributors must be empowered and incentivized to help drive that performance. But the challenge there is, while they can be empowered and incentivized, if they don't have the tools, that can be a problem as well. So while being equipped with the necessary tools and skills, such as problem-solving expertise, et cetera, to drive that success is also important. Again, these lessons learned are coming from, frankly, an awful lot of failure. You can imagine over the course of the 3 to 4 years we've been at this, this hasn't worked magically every single time. We've encountered a number of challenges along the way. And these were the kind of the insights that we've gained along the way, that if you don't have some of these ingredients, trying to deploy this type of approach in a particular department or a particular function or with a particular executive's sets of departments becomes incredibly challenging. And I will say I'm incredibly blessed by having an executive team that is absolutely 100% committed to driving this kind of alignment with me. So with that, I'd like to thank you all for your time and kind attention. Hopefully I prevented a bit of a food coma. I don't know, we'll see. And again, I'd welcome any questions and, or comments you may have. Oh, a lot of hands, Randall.
Okay, let's start right here.
Thank you. It was a great job.
Thank you.
Okay. So I'm interested in the process that you use to collect the areas of improvement from the frontline staff, and then how did you choose which ones to implement?
I didn't choose a lot of them, frankly, because it's happening at a very organic level, at the department level. So the way we bring visibility to it, one of the elements on the Lean Daily Management board, or the visual board that you saw, is a place for, as they're having that huddle, what could we have done to improve yesterday's performance? Idea goes up for a project, right? And then there's a discussion that's happening with the folks who do the work to say, what could we do about that? What are we going to do to solve that? And it's essentially the frontline manager or supervisor that's essentially conducting that huddle, working with their team to say, yep, that's one we're going to implement, or this one doesn't make sense, and here's why that doesn't make sense. It might have it might be one of those scenarios where it improves it for my department, but it's going to push waste downstream. So hence the gap between 2,500 thought of versus 1,500. Not every idea is one that is going to move forward. So by and large, a lot of those ideas are ones that the folks on my team, and we have about 17, 18 people on my team, we're not necessarily approving those to get done. What we're working on, about half the team's working with deploying the system that others are using, and about half the team is focused on driving those key enterprise initiatives that do get approved by the C-suite of the organization. Does that make sense?
Dan, a quick question about who's responsible for maintaining these visual boards, keeping that data current, and et cetera?
It is the leader over that area. They can delegate, of course, because that's a way to develop future leaders, is to kind of shift that responsibility and share that amongst the group. So each leader is empowered to make that call, but the leader, from an accountability perspective, the leader over that functional area or department is responsible for it. And then I mentioned the kind of rounding that happens by executive leadership. It's kind of one more reinforcement mechanism that says, hey, if I go by and it's not up to date, I'm probably going to send you an email and say, hey, what's going on? And not necessarily me, but that person's one up, for example. Make sense?
I have a question about the providers and the employees. You've got quite a different business model to other hospitals. How do you make sure that that they completely understand your business model and the way that they're approaching patients? Because they may be used to doing things in a different way.
It's a great question. You probably got a sense from the presentation itself that culture and mission and vision is really critical and important at CTCA. A lot of time and attention is paid to employee onboarding and orientation. So there is a fair amount of work that goes into it. It's another reinforcing mechanism that I didn't put in here. But you know, day one when you walk in the door, you're learning the history of what we're about and why we do what we do. Living day of the life of a patient. So there's a ton of opportunities that are provided to stakeholders coming in to kind of walk that life of being a cancer patient or a caregiver, so they get a sense of what we're trying to do.
So this is very impressive. I'm curious, how do your patient outcomes compare to other U.S. averages or even other treatment center averages?
I'd stack them up with anyone else's. They're very, very strong. The trick with outcomes is they're measured differently, yeah. And it's hard to compare healthcare institutions because it really depends a lot upon the types of patients you're seeing, the stage of the disease of the patients you're seeing. For example, CTCA sees a fairly high mix of complex late-stage cancer patients. So the outcomes there, while strong, hard to compare against an institution that might be 80 to 90%, you know, early stage, treatable, and in a very treatable stage.
Thank you.
Make sense?
Absolutely.
Well, let me put it this way. Both my father and my mother, they were diagnosed with cancer within about 9 months of each other. One with prostate and one with uterine. They both treated with CTCA and are doing great. Fantastic, actually.
Other questions? We still have a few minutes.
You talked about your enterprise performance management, essentially your system.
Could you speak loudly, please, until I get there?
Stand up so we can hear you. Sure. You can
Go ahead.
Go ahead. Thank you, sir.
You're very welcome.
Daniel, you talked about your enterprise performance management and how your KPIs, strategic KPIs, feed into that system. Is your team responsible for actually reporting out, or do you use any software to actually package that product and share with the organization?
Certainly the data is coming out of applications, right? We have a number of, IT systems related to our electronic health record, scheduling systems, et cetera. So by and large, most of that data is coming out of those systems of record, if you will, for so we have, when we look at our patient growth, we have systems that comes out of. So we don't have any kind of one, and then it all kind of feeds up into a dashboard, if you will, that we've kind of created through a number of different applications, like Tableau, for example, is one that we use to kind of visualize it. But beyond that, I mean, there's not like an enterprise system that looks at all the projects ongoing in a real-time basis, if you will. Yeah.
Was there another question over here before I run over there?
Get your workout ready.
In terms of how you incent employees, my assumption is a risk that if it's too employee-centered and not team-centered in the culture of hospitals, you could actually create a problem and not have a solution. How have you managed that risk, and how do you deploy effective ways of creating a highly effective, high-performing team atmosphere?
Sure. So a couple different ways we balance that. One thing I mentioned was kind of the stakeholder incentive model. It's essentially a bonus plan that incentivizes every single employee at the same rate based on the performance of the organization. And it's based on those TrueNorth metrics. It's not based on individual performance in that regard. It's based on team, right? So if we achieve what we need to as an organization, everyone's incentivized the same. Now, on an individual performance management perspective, we kind of have the two parts. It's what did you get done? And if I get very granular on this, the department leaders, their goals are actually achievement of the KPI targets that are specific to their department. So, as is the team. So half of their compensation is based on what the department achieves. And then there's that 50% that's based on what did you specifically do to demonstrate kind of the behavior we're looking for, right? So it might be you came up with 10 great ideas for projects, 4 of which got implemented, you helped deliver on an enterprise project, et cetera. So those are the ways that we try to balance kind of the team with the individual working together. But it's certainly a tricky balance.
It's really interesting that you have a lot of your focus day to day, really people keeping their finger on the measure of how we're doing, and here's what we said what we do. How have you built in a process or an approach so you can sort of take that step back from the day to day and look at your performance kind of like trend line? Kind of not down in the weeds, but that next level up. How have you built that into your system?
So the department level KPIs, for example, we look at those trended. So the department leaders it's not just like how are we doing that day. They're stacking those days together to say how is that looking on a trended performance. Those department level metrics roll up to kind of a executive level dashboard, of course, that's kind of looking at the macro numbers. Many of which are going to coincide with those TrueNorth metrics we talked about. So, and those metrics are reviewed at least monthly. Used to be every 2 weeks, but now we backed it off to a monthly cadence with the CEOs of the hospitals, the CEOs of the enterprise, the CEOs. So the entire executive team is getting together on a day-long meeting, if you will, once a month to kind of review this and making sure that we're performing where we need to. And if the initiatives we're leading on an enterprise level are not meeting the desired target, or there is a change in the market that requires us to think differently, there's that opportunity there.
So there's a feedback loop then, that's
Absolutely, yep.
So Daniel, good presentation. So I have a question and a follow-up question based on how the first one's answered. So what I see in your presentation is you're using either the Studer group and or working with the Baldrige criteria. Is that a correct assumption?
We're not actually using either one. I'm actually, I've had experience with Baldrige, and I also have had experience with the Shingo model. I don't know if you've had that for operational excellence. For our culture, a Shingo model is probably would fit better, but we haven't necessarily adopted it one for one in terms of how we go about it.
So I wasn't exactly on the target,
but close.
Can you talk about how? So the theme of the conference is bridging the strategy execution gap. So can you talk about how those kind of more holistic models help you do that, or what the impact it's had on your organization to bridge that and integrate it?
Yeah, I think again, this is just my perspective. I've worked in a number of organizations, and I think a lot of times we put the onus of bridging that execution gap in the hands of a few folks. These are the 40 or 50 top leaders in the organizations. You guys go do this. Make sure that we bridge this gap correctly. But I think the gap for me is that we need to figure out ways to engage all levels of the organization and keep their mind on what that gap might be. Because it really requires execution at a number of different levels, at a strategic level, at an operational level. And you need to have a framework, in my mind, that gives folks what I'm going to call operating intent. Right, and I think what we've done fairly well is by giving kind of meaning to these pillars and giving metrics that folks can interpret based on the way that their supervisors and leaders are explaining it to them. It makes it clear for the frontline stakeholder to understand what their role in that is. So Certainly, you can have a fantastic impact by just focusing on, the critical 10 to 20, or I was in a presentation this morning where someone had 900 strategic initiatives that they drove, ran a much bigger business than what we have. But it was fascinating, the level of commitment to those initiatives, and they're driving tremendous impact. So I don't mean to discount that by any means, but I think in order to really harness the power of an organization, you have to engage the group. And a model, back to your point, Shingo model, the foundation of that is respect for people. And that's where we tend to kind of start with making sure that we respect people enough in the organization to give them the credit to understand where we're going.
Okay. You talked about the innovation. I was thinking that it is primarily on the process side of innovation, how to improve the process, but has it helped you in taking it back to the research side in providing better treatment solutions to cancer patients?
Absolutely. Yeah, the physicians, I will say this is an area that I would like to see more involvement of, but our physicians are really engaged in some pockets in these huddles. It's not everywhere. I would say to some level, the providers are a missed opportunity for us that we're trying to work out. But there are a number of things we've done that have come out of huddles like this that have improved the quality of care that we're providing on a very tangible clinical level that says, hey, why don't we, as a matter of a discharge of a patient, why don't we do things a different way? And then that idea is then disseminated to the like departments at other facilities or similar departments within the same facility. So we have evidence of that. And the other thing from a strategic perspective, I'm also blessed to have colleagues. We have a strategy department, of course, that's kind of looking beyond kind of the current day operations, which is what are the new business innovations we should be looking at, the add-on services that maybe we don't have today but should have. And then as we go to bring those to execution, that's where my team kind of comes in and says, okay, how would we design a process to make sure patients can, elegantly navigate to that new service? Or how do we carve out the patient population that's appropriate for that particular treatment, for example?
Thank you, Daniel, for your sharing of your experience. I'm curious, you have, I presume, number of affiliates across Americas, right?
We have 5 hospitals and 3 recently opened outpatient centers, 2 in the Arizona, Phoenix market, and 1 in Chicagoland here.
Great. So the question that I have is, with having all these people remotely located, how do you mobilize everybody to go to the TrueNorth, and everybody understands the TrueNorth and then works towards it, shares experiences across? So how do you do that part?
So part 1 is a lot of communication around what we're trying to do, the implementation of the visual management board and the huddles that puts it in front of everybody's mind every day. But the last piece that you mentioned, frankly, is an area of opportunity for us. The first kind of stage of this was to let's get the foundation in there. But where I'd like to go, one of the areas our team is looking at going is, actually there's 2. One, we want to increase the problem-solving aptitude of the frontline stakeholders. That's one. But the second is sharing across sites. I suspect this is a challenge for many of you who have separate locations, trying to share a best practice here to a best practice there, because there's cultural dynamics that fit in there, or change dynamics, maybe I should say, that not invented here, I don't want to do it, right? So we're working through some strategies right now on how do we promote that cross enterprise sharing, but I don't think we've cracked that nut yet, in my estimation. Yeah.
My question, and again, the questions have all been great, and thanks for the answers. I think I'm probably the final one. You talked about having all the stakeholders understand the why. Why are we doing this? What's it mean to me? But you also talked the success beyond that is giving them the tools that help enable it. Can you expand a little bit on what kind of tools you provide or what you offer?
Yeah, so from a training and coaching perspective, we have a couple programs. One is what we call our A3 program. It's essentially everyday problem solving. It's actually where we started, and unfortunately, While the success of the program was pretty strong in terms of getting folks engaged and leading projects, what we found is that sometimes the projects weren't necessarily aligned with any kind of true north. So then what would happen is you'd have frustration start to build because stakeholders would attempt a project, couldn't finish it because they couldn't get the support, it wasn't a good project, it wasn't aligned to where we were going, and it actually led to this situation where my folks were doing a lot of training. The impact was spotty. I wouldn't say it wasn't good. There was certainly impact coming out, but it wasn't consistent, right? Project to project was kind of all over the board. And so we actually, so that's one program we have. Another is for more sophisticated problem solving. We have green belt and black belt programs as well. But what we found is we kind of put a pause on that until we could get this in place. A lot of what we talked about is having kind of the daily management and the framework in which we look at our business, because we wanted to make sure that when we reinvigorate those programs, we have folks focused on the right thing as opposed to just, hey, that seems like a good idea. Does that make sense?
Okay, I think we're out of time here. Before you run off.
Oh, geez. Thank you.
We'd like to thank you for your presentation.
Appreciate it.
It was great.
Thank you. Thank you so much.
So just a reminder, if you want to go with one of the dinner groups, you can sign up until 3 o'clock. So we're adjourned for the afternoon sessions. Thank you.